Welcome to Occupational Therapy Conversation. And in this episode, we're going to talk about some of the processes of occupational therapy and some of the expectations that I'm hoping be a standard for a lot of things. So there'll be a few things, particularly when it comes to the OT role in discharge planning. What is it really that we do during discharge planning? This is what's interesting for me. What I find interesting is the fact that discharge planning is appearing like a specialization of occupational therapy. In fact, this is a process, guys. It's a process. Discharge planning is a process. When you see a patient, there is a point where you start having some sessions and having some interventions with your patients. You have the assessment phase, you have an agreement that's going to be a transaction that as an occupational therapist, you will provide the service and the patient is agreeing to it. Okay, we don't have to worry about the payment because in the United Kingdom, generally, if we're talking about NHS, it is free at the point of delivery. So there is that admission from the patient and that occupational therapist will come in. And at the end of it, you will be discharging the patient. For every service, there is a service opening and there is a service closure. And when you close the case, it just meant that you have discharged the patient. And that is where it is supposed to be. Now, discharge planning is such a huge thing and is such a huge issue that it appears like this is the focus of a lot of occupational therapists to a degree that it's almost like it is a specialization. So we can't get away from this. And because we can't, we might as well talk about it. What would be our role and responsibility when it comes to discharge planning? And there are different components. There are different parts. So we'll be talking about processes. The first process being the process of screening and assessment. And what would be expected from an occupational therapist? What I'm hoping is that all patients who are referred to occupational therapy will be screened. And occupational therapists will do this screening because we want to establish if there is a need for further full occupational therapy assessment and OT intervention. So screening is really saying, is there a way? Is there a need for occupational therapists? Is there a need for more assessment? So that's a screening. Technically, when the nurse finds that the patient lives alone, they've already done the screening. There might be a problem, so they're consulting an occupational therapist by referring the patient over. So we are hoping then that if a patient's been screened or been highlighted to us, that we can screen these patients and that we can screen them. And the screening process can take the form of either by looking at the electronic patient records or through verbal screening or a handover from a different multidisciplinary team members or from a direct observation. And these are the forms of screening. You identify whether the patient would need further assessment. OT screening can take place if a patient has been referred to us at least 4 hours prior to the planned hospital discharge. And I think that's just fair, isn't it? If you're working in a hospital and the ward is really busy and we are just the afterthought and the patient's already, there are issues, the patient's in a wheelchair, you just can't expect that we'll be able to see the patient. So that's not fair. So yes, but should it be highlighted in the morning, then yes, we can go and have a screen and then we'll delay the discharge if it is needed. Yeah, there we go. And should there be no need for further assessment, the outcome of the screening should be recorded in the electronic medical records or in the patient's electronic records. Okay? So when you do the screening and you've identified that there's no need, you document that formally by writing it down in the medical notes. The next thing is for those who require full occupational therapy assessment, the assessment then can include few things. When you're doing your assessment, there has to be the baseline functional component of the patient. if you're an OT working in the ward where you're overseeing the general performance. So we need to have a baseline functioning of the patient. We need to have a contextual assessment, and these contextual assessment, which would mean an assessment of the home environment, their social situation. So context, guys, these are contextual assessment. We might as well use these things because these are our terminology. Okay, contextual assessment. And what is important is we do functional assessment. When you're doing assessment, you establish the baseline functioning and you do the contextual assessment as well. So occupational therapists will assess essential impaired performance components. So if there are any impairment with performance components, and if we categorize this either a problem with cognitive, physical component or psychological, psychosocial component or affective component, then occupational therapists will decide the appropriate assessment tool that needs doing or that needs assessing for situations like this. So we are entitled to do that. You're a clinician, you hold your license, so you decide what assessment tool you would be needing. That's it about screening and assessment. Next thing, after you've screened and after you've done the assessment, the next thing that you need to do is you need to plan your treatment. Sometimes this treatment is happening very quickly in your head, and it's happening so unconsciously that you don't know that you're doing it. So when somebody asks you what you're doing, you don't know, but you need to know. You need to be able to verbalize this. So treatment planning and treatment implementation. Occupational therapists will plan and implement the appropriate treatment intervention that is suitable for patient's need given the parameter of time set by the medical team. Okay, why am I saying this? Because the medical team is the one that's setting that's the gateway, a medical fitness. First and foremost, patients go to the hospital because of medical reasons. They did not go to the hospital because of occupational therapy reasons. So when the doctors and medical team are saying, we're happy, the reason why they came in to see us is already resolved, then that's the parameter of time. They're the ones that are dictating the time. So given that parameter of time, then we will decide what kind of intervention. Because if the time is long, we have a long time to work with a patient, then we can do restorative interventions. But if the time is short, then we can do supportive interventions. We can get reablement care. We can get adaptive aids. But if you give us about 2 weeks, there'll be a few more things that we can do. So the parameter of time is dictated by the medical team. Okay. And when it comes to treatment planning and treatment implementation, occupational therapists will make autonomous clinical decision if patients will receive or will be provided with restorative intervention, preventative intervention, supportive intervention, okay, or alter intervention. All of these things, at the end of the day, the one that will make that decision is the occupational therapist handling the case. There is no pathway for this because every individual is unique and every individual's case will have to be managed by the attending occupational therapist. That is part 2 or section 2. Now, on to section 3, discharge planning and responsibilities. What would be the responsibilities of an occupational therapist when it comes to discharge planning? Okay, OTs having the skill of prognosticating functional progress of patients and with consideration to the trends of their medical progress and their physical recovery, we will make recommendations to the multidisciplinary team, including the discharge planning team, of the appropriate discharge pathway that is suitable for the patients. Okay. We are measuring their progress, and if you know that medically they're improving, functionally they're not as good, we are in the position to make a recommendation as to where they can go afterwards. Home with care, rehab facility, enabling care or discharge to go home, optimization beds. Occupational therapists can see this because we have an overview of what's happening. We don't just look at our patients, we look at the medical status, we look at the social context, we look at their prognosis, physical and functional prognosis. There we go. We will make recommendations regarding where these patients can go. The next thing, occupational therapist as part of our treatment planning. Occupational therapy as part of the treatment planning and treatment implementation process will advise the MDT of the functional criteria and conditions that are required for patients to go home. And this advice will be regularly noted in the OT notes for the MDT to refer to. MDT being the nurses, discharge planning, physiotherapists. So that's there. What am I saying here? What I'm saying is this. If we see a patient and that there is a functional, we can set the criteria. And what are the criteria? What are the functional targets that this person needs to do? They need to manage the stairs. We can set that up. And then the physios can do it. Or if they can't do it and we know that they won't be able to manage the stairs, we can set the criteria as the patient needs to have access to their sleeping facility. And what do we mean by that? It just meant that we're going to have to put the bed downstairs. Okay? What are their functional criteria? They should be able to wipe their bottom. That's one criteria. They should have means to go home, either by transport, hospital transport. That's one. Another criteria that's required is we can set that for this person to go home, we need doctor's clearance. We can set these things up. And if we do, we write these things down. Okay? It is just the right thing to do that anything you do will have to be documented. There you go. We will set the criteria that is required for a person to be discharged home. Now, with regard to equipment, should essential equipment be required to discharge patients directly home from the hospital? This needs to be reviewed by the occupational therapist and their family, and will monitor, and the OT will monitor and will advise, needs to advise the ward that these equipment's been delivered. So it's not just the ward, but the MDT as well. There are things that are essential for getting the person home. Some equipment that's essential. And what are these? If you have hip precautions, chair raisers, these are essential. If a person cannot move without the walking frame, this is essential. If the person has a problem with moving and handling a hoist and they need carers, of course this hoist is required. And these are essential for going home, right? Commode, if it is required that the patient cannot manage to go and access their toilet facility, and having a commode is the one thing, yes, you need to provide these things. And nowadays, because equipment are being purchased by family as well, so it's no longer the sole responsibility of the occupational therapist to do this. It's now a collaboration between the family and the therapy team, okay? Because the family might just have to buy their own hospital bed, or the family might have to buy their own bed or shower chair. They just need to inform the team, okay? That's that, okay? And with regard to equipment, so I'm not just talking about commodes or raised toilet seat or toileting equipment. These are very minor things, okay? The adaptive aid that is required, okay? And we do that, okay? Now, when an occupational therapist as well will complete a functional status report for patients in need of reablement care, or should patients be planned to be discharged to a rehabilitation unit, right? How would the carers know what needs to be done? Which information is vital for them? They don't get this from nurses. They don't get this from physio. They get it from occupational therapy. They don't get it from discharge planning. Maybe they can send information, but where would they get this from? From occupational therapy. Okay, So we need to do a functional status report. Occupational therapy, where medically suitable, will then continue to functionally monitor and will continue to perform functional optimization sessions with patients and will advise the MDT and the discharge planning team if they have achieved the functional targets needed for discharge home, on which case patient's discharge destination plan can be changed, right? This is our responsibility when it comes to discharge planning. If the person is targeted or aimed to go to another hospital, yes. For another medical reason, fine. That's the plan. But while that is the plan, we continue to see the patient, provided that it is medically allowed to do the therapy, to do the rehab. Because as soon as the patient achieves a functional target that is required to get them home, that means we can get the person home. Right. That's another part. Discharge planning responsibilities. Next section is about the discharge collaboration responsibilities relating to discharge planning. What are our responsibilities? What's going to be our commitment when it comes to collaborating, when it comes to discharge planning? This is one. Occupational therapists will be represented during whiteboard meeting, but only with the purpose of two things. There's only two things that we need to know during the whiteboard meeting, or we need to do during whiteboard meeting. One is to identify cases that needed urgent OT screening and assessment based on the information that the MDT is providing. You can tell us, MDTs can inform us during that time, because that's a good time to catch occupational therapists. That's one. And then the second responsibility in the whiteboard meeting is OTs can make recommendation in terms of the adjustment of the expected date of discharge this is because we are considering the patient's medical condition, their physical capabilities, with the consideration for their social concerns and some contextual barriers that are limiting, that are stopping a person from being discharged home. Okay? Making recommendations. Only two things that we need in a board round. Who are the patients that we need to see? And we can adjust the EDD. Okay? Those are the things. Another one in terms of our discharge collaboration responsibilities, occupational therapists will closely work with social care coordinators for those cases who are in need of reablement care. Okay? What do I mean by that? It meant that if there is a need, we will alert them, we will inform them, we will tell them that this is on standby just for your awareness. Then we will make a functional status report. When that's completed, we will let them know. Okay? There is that direct collaboration so that they don't need to troll into the occupational therapist's notes. We make people's lives easier by being courteous enough to inform them that their action will be required. Okay. And then occupational therapists will take part in case conference and complex discharge planning meeting for cases that has complex discharge need. So if there is a need for us because there is there's difficulty in terms of discharge planning, then occupational therapists will be there. Another one, and the last part in terms of our responsibilities in terms of collaboration, it means that we will update and notify the ward nurse or the nurse coordinator of any urgent or arising issues that will have a bearing on managing the patient's discharge. Say, for example, all is well, and then we came across with some information about that would stop a person from being discharged. We will inform the medical team or the discharge coordinator straight away. Equally, the discharge coordinators have that responsibility. If they identify that there is an issue, inform the team that is suitable to address those problems. You can tell the occupational therapist, we can address that, provided that it is at least within 4 hours. Give us some time because we won't have time to actually respond quick enough. And all we're asking for is 4 hours at least. Okay, there we go. Now, when it comes to documentation and reports, occupational therapy will provide and document the following documentation types. So there are types of documentations on which we are addressing and doing, and this will be available and recorded in the medical notes. You will find these type of notes in the medical notes and the medical records, and these notes can be used for handover to other services, and it can be used for discharge planning with the exemption of OT session notes. Okay, session notes are just session notes. There are a few things which I will explain to you. The first one is the OT initial assessment note. It's our initial contact note. The first time we see them, these contact notes will include the following data. It will include the social and contextual information, which includes the details of home environment, the social support, adaptive aids that's suitable or that is required or that is available to the patient. That's one. On the assessment note, we will have the care measure. And what is care measure? This is an occupational therapy tool that is used to log and monitor patients' functional abilities. And this tool is the foundation for occupational therapy functional status report. It is a rehab tool that we are using so we can monitor the progress of our patients. Okay, OT session notes. Session note is a record of every individual session that OT has provided. It has the statement of consent, it has the statement of intervention, and it has a section where we have the plan and handover. So what I'm asking for you guys to have a look at is this plan and handover. That's the part where you can have a look at what we are going to be doing next. And usually, it's most of the time, it is always the most recent note. Yeah, we don't have to look back into the notes as to what the plan is because the current plan and handover is always there. That's always updated. You don't have to go and look back. Okay, now there we go. The third type of intervention is OT functional status report, and OT functional status report is completed. This is completed by an occupational therapist, and this report is essential in setting up reablement care. It is important when referring patients to rehabilitation units and to other external services. It is very essential to have this functional status report. You can have your discharge summary, you can have your discharge report. That's essential for the doctors. But whatever it is that's happening out in the community, where they want to go in terms of the function, what management needs to happen, it has to be the functional status report. Okay, now the functional status report will have parts. It will include the baseline function of the patient, the ADL performance report with functional goals if necessary, and it will have the care measure as well. It will also have the occupational therapy plan and handover. Okay, so that's the functional status report. Now, the last part, the last note is the OT discharge note. This has been and has always been that's the note that's non-existent to a lot of places. Okay, and what the expectation is that OT will have a little section in the medical discharge note. No, occupational therapy will have a thorough discharge note, but this is proving to be difficult, but this is our aspiration to be able to do this. And what should be in a discharge note? Occupational therapy will note that the patient is discharged from the service. Every time we're done with the patient, we're not going to leave the case open. Look at our notes. It should indicate that patients are discharged from OT, and it should be on the plan and handover. If we've discharged the patient, look at the plan and handover at the end, and that would be the discharge note. Now, with regard to discharge follow-up and responsibilities, what do we do from an occupational therapist's perspective? The first one, occupational therapists will close the case and will indicate that patients have been discharged from the service, and this will be recorded in the notes. Patients' discharge notes will be recorded either as a detailed discharge report or as part of the last plan and handover notes. Sometimes, if it is very thorough and it is so complicated, we will endeavor to make a functional status report and a discharge summary. We can do that. It's not a common practice, but should there be a need for us to do that, then we will make a separate note for that. Okay? And should patients need it, patients will be provided with essential information media to the patient and their family as required. What do I mean by information media? A printed media, a pamphlet, a booklet, an instruction leaflet or something. We will provide them with the media. At the moment, that is our aspiration. Should it be, we'll go high-tech in the future, we're aiming that patients will get some video instruction material that we can give to our patients. Another thing, should a follow-up referral to external services be required, like for example, community therapy team or early supported discharge team for stroke, or a detailed handover is required by a receiving trust, occupational therapy will initiate all the referrals and handover, and these follow-up referrals will be recorded in the notes that's our plan, that's what we're going to be doing, and we will indicate if those report and those handover is essential in discharging a patient from the hospital. Okay? There we go, guys. Those are some of the responsibilities of an occupational therapist with regard to goal and discharge planning. It's the process, isn't it? Just to let you know, it's the process. So whatever it is that's happening in terms of the assessment, treatment planning, leave that to the skill of the clinician, of the occupational therapist. But the process, we are committing to the process, particularly with the screening, our response time, the things that we needed to do. Everything is laid down in terms of how we are going to be collaborating and what are the responsibilities when we need to collaborate with the MDT. Okay, guys, I hope you learned a little something today. So thank you and bye.